This video will deconstruct and simplify glaucoma drainage device implantation. Though trabeculectomy is still the gold standard procedure, glaucoma drainage devices have certain clear irreplaceable indications like ICE syndrome, glaucoma after chemical injury, corneal and vitreoretinal surgeries, failed trab and neovascular glaucoma. There are two main types of GDDs, valved and non-valved. GDD diverts aqueous to the equatorial reservoir unlike a limbal bleb with trab. Ahmed FP7 is the most common valved GDD used. The valve here is not a true valve but a flow restrictor guarding against hypotony. Priming is an important step to open the leaflets of the Ahmed valve. In India, RD is the most common non-valved GDD. This needs temporary flow restriction till the capsule matures. Complete ligation of non-valved devices cannot be overemphasized. Though subtle differences exist, none of the two is superior in the long run. If so, how to choose the one for our patients? It depends on the type of glaucoma, condition of the eye preoperatively, and the experience of the surgeon. There are, however, certain indications when a valved implant is better than a non-valved. Superiotemporal and inferionasal quadrants are the most preferred locations to secure the plate of the GDD. Superionasal is the least preferred due to its close proximity to the optic nerve. Inferiotemporal quadrant can be utilized, but it is not a great option cosmetically. Superiotemporal is the best place to implant a GDD. However, location depends on pre-existing pathologies like conjunctival scarring, scleral buckle, scleral thinning, and high pass. With these synechially closed angles, there would be adequate sulcus to put the tube in comfortably. After choosing the quadrant for the plate, we should decide on the tube location in the eye. It is important to put the tube away from the cornea at all times. Tubes in anterior chamber should be 2 mm long. The ideal entry point should be at the scleral spur or trabecular meshwork. This will ensure adequate distance from both the cornea and iris. These are some of the suboptimal entry points for the anterior chamber tubes. Note the focal tube corneal touch in these images. Gonioscopy of the tubes will also help us to find the exact entry points of the tube. Note the quite anterior location of these tubes. Apart from slit lamp and gonio, ASOCT will also help in understanding the dynamics of the tube in the eye. Though the tube looks innocuous in the slit lamp image, note the actual corneal location of the tube at the entry point. These suboptimal locations in the anterior chamber will lead to endothelial cell loss irrespective of the type of the GDD as shown by various studies. This patient ended up with an inadvertent long tube which resulted in mild corneal edema. If no improvement is achieved with conservative management, one should not hesitate to trim these tubes. Point to note is not only the location but also the fluid currents around the tube affect endothelial cell loss. Putting the tube far away from the cornea is always wiser to prevent corneal decompensation later. This patient was noted to have a long tube after final conjunctival closure and hence tube trimming was done with the Vanna's scissors. Note the loss of bevel after tube trimming. Sulcus tubes are inserted in the posterior chamber behind the iris. Sulcus tubes should be long enough to be visualized through the pupil and are an excellent option in pseudophakic eyes. Note the good separation between the cornea and a tube in sulcus in the left side when compared to a tube in anterior chamber with mild corneal edema. Less risk of endothelial cell loss with sulcus tubes is well proven. These tubes, because of the sulcus entry, have a small transient risk of hyphema. These usually resolve with conservative management with steroids and cycloplegics. Pars plana tubes should be long and need to be combined with complete vitrectomy to avoid tube occlusion by vitreous remnants. It is an excellent option in eyes where tubes cannot be inserted in the anterior chamber or sulcus due to heavily compromised corneas. The entry point for pars plana is slightly posterior compared to the tubes in anterior chamber or sulcus. Note the position of the tube is well behind the IOL in these images. Now that the plate and tube is positioned, it is important to cover these hardware with appropriate material to avoid erosions and infections. Sclera and cornea are the commonly used grafts to cover the tubes. One can create a scleral flap and insert the tube under the flap if patch graft availability is an issue. Note the well-positioned tube in the sclera. Alternatively, one can use a long scleral track for tube entry. It is important to note that some patients can have recurrent patch graft melts and tube or plate erosions. Tube erosion is a risk factor for infections and should be given urgent care. Early and small erosions can be managed with lubricants, topical antibiotics, and oral doxycycline, but large and late erosions will need surgical revision. Plate exposure is a serious complication and conservative measures won't help. Explantation followed by diode or GDD in a different location at a later date is a better option. Post-operatively, tubes can get occluded by various materials including blood, fibrin, vitreous, lens capsule, etc. Most of these resolve with conservative measures. Obliteration of the ridge of the implant is an important sign of tube opening and must be looked for at all visits. Serial follow-up B scans will also help to identify the fluid-filled cavity around the GDD end plate. Ripcord suture stent is a technique to avoid precipitous IOP drops during tube opening. A 3O multifilament nylon suture is threaded into the tube at the time of the surgery. Removal, if needed, can be done after 6 weeks after dissolution of the external tube ligature. Hypotony is a serious vision-threatening complication after GDDs. Meticulous attention should be paid to tube entry to avoid peritubular leaks. Hypertensive phase is more common with valve devices. This is a difficult problem to deal with and patients will have to be started back on AGMs eventually. It is now conventional wisdom to start AGM early on after MF glaucoma valve. When the IOP spikes more than 10 mm Hg, tube visualization can be a problem in some patients. Gonio can sometimes help to identify retracted tubes. Sulcus tubes can be imaged well with ultrasound biomicroscopy. Sometimes a simple dilatation can help to visualize the tube tip. With pars plana tubes, one can utilize UBM to trace the tube into the vitreous cavity. Careful case selection and meticulous attention to the surgical details can help mitigate complications after GDDs. Imaging techniques can improve our understanding and help us better manage our patients.